I'm presenting on the comparative efficacy and safety of conventional versus accelerated corneal cross-linking for keratoconus, 1-year outcomes from the SafeSide Keratoconus registry study. This is my financial disclosure. Corneal collagen cross-linking is relatively an invasive procedure for stabilizing progressive keratoconus. It is done with UVA and riboflavin to induce bones in the corneal stroma to increase biomechanical strength and stability. Conventional cross-linking is also known as Dresden or standard protocol, done with 370 nanometer UVA wavelength at 3 milliwatt per square centimeter intensity for 30 minutes. Accelerated cross-linking is done with higher power UV for shorter duration. It is based on the Bunsen and Roscoe rule of reciprocity, which states that regardless of the time at which the energy dose is administered, a photochemical reaction is directly proportional to the total energy dose. However, biochemical change may not be the same as photochemical change. The aim of this study was to compare the efficacy and safety of conventional versus accelerated corneal cross-linking procedures for the treatment of keratoconus using the real-world data from the SafeSide Keratoconus registry. This was an observational study utilizing the prospectively designed SafeSide Keratoconus registry database. We defined accelerated cross-linking as the one with 9 milliwatt per centimeter square UV power for the duration of 10 minutes. The primary outcome measures included change in visual acuity, Kmax and K2, and the secondary outcome measures included change in minimum corneal thickness and the incidence and prevalence of adverse events. The statistical analysis included descriptive analysis, Lewis curves to visualize the changes in outcomes, and mixed effects regression models to calculate the adjusted changes in outcomes. 725 eyes from 588 patients met the inclusion criteria. Age, gender, visual acuity, Kmax, K2, and minimum corneal thickness were similar between the groups pre-operatively. The participants came from 24 sites in Australia, New Zealand, and Italy. 277 eyes were there in the conventional group, and the accelerated group consisted of 448 eyes. Age and gender distribution was similar between the groups. The mean habitual visual acuity improved in both cross-linking groups as seen in this figure. The difference in mean changes in visual acuity was not statistically significant between the groups. There was a decrease in mean Kmax in both cross-linking groups. However, the difference in mean changes were not statistically significant. Similarly, there was a decrease in mean K2 in both cross-linking groups. However, the mean changes were similar between the groups. There was a substantial reduction of minimum corneal thickness, particularly in the first 3 months, which gradually increased. At 1-year follow-up, the mean changes in minimum corneal thickness were similar between the groups. Most of the adverse events observed was the clinically significant haze. The proportion of eyes with clinically significant haze within 1 year was higher in the accelerated group. Most of the haze occurred within first 3 months, and it gradually resolved, so it was transient. And at 1-year follow-up, the prevalence of clinically significant haze was similar between the groups. Overall, putting all adverse events together, the prevalence of adverse events at 1-year follow-up visit was similar between the groups. So both cross-linking procedures were similarly effective for stabilizing keratoconus and for improving visual and keratometry outcomes. The prevalence of adverse events was similar at 1-year follow-up visit, and overall the prevalence was low. Thus, we concluded that the accelerated cross-linking may be the recommended procedure for time and convenience. This large-scale international study had several strengths. The existing studies, which are similar to this study, are limited by sample size, and these are single-center studies reporting inconsistencies. This was the real-world study, which therefore reflects the routine clinical practice. Thank you. And if you have any questions or if you would like to join the SafeSide Keratoconus registry, please contact us.